Okay, before we come to that, I would like us to respond to some few questions. Look at that question. Somebody to read it.
An 18-year-old female patient is brought to the emergency department due to drug overdose. Which of the following routes of administration is the most desirable for administering the antidote for the drug overdose?
Good. First of all, an antidote is a drug that can be used to counteract the effects of another drug. And we can use it in case you have taken a drug that is having so much toxicity. We can give an antidote to reduce the toxicity of the other drug. So, and those antidotes, they just depend on the things we are talking about in terms of pharmacokinetics and pharmacodynamics. For example, if we realize that a drug will cause the elimination of another one faster, now that one can be an antidote, because once the elimination happens faster, then the toxicities are also eliminated faster. Okay, can we now respond to that question? Choose the best one. Who read? Now I cannot see you once I've gone to the screen.
Okay, I think the correct answer is intravenous.
Why?
Because I think this is a condition of maybe emergency. So intravenous is the most effective, yeah.
Okay, but use some words that we have used in this pharmacokinetics.
I think it has rapid onset, then it has 100% bioavailability.
100% bioavailability. Thank you. Let's see the response. Okay. Question 2. Someone to read that? Hello? Hey, Mo. Somebody has to read through that?
Just me.
1.2.
Okay, 1.2. Drug A is a weekly basic drug with a pKa of 7.8. If administered orally, at which of the following sites of absorption will the drug be able to readily pass through the membrane?
Okay. At which place? What are we looking at here? We are looking at which rate the drug will not ionize completely. If it ionizes completely, absorption is reduced. And the drug will not ionize completely if it's not having a reaction, if it's in a medium that it looks like itself. So which one is closer to that? Okay, let's go for the other one. Ah, 1.3. Somebody to read. Hello.
Okay, let me read.
Okay.
KR2250 is an investigational cholesterol-lowering agent. KR2250 has a higher molecular weight and is bound to albumin. KR2250 will have a dull apparent volume of distribution. Read.
What factors are we picking out in that sentence? High molecular weight and very highly bound to albumin. So in this case, what will the volume of, how do those two affect the volume of distribution? Increase or reduce? When it's highly bound, then it has very little to move around. Okay? So the answer will be low volume of distribution, because much of the drug is bound to albumin, and therefore very little will be moving around. Next, that one, 1.4.
A 40-year-old male patient, 70 kg, was recently diagnosed with infection involving methicillin-resistant SRS. He
Staphylococcus
received
aureus.
okay. He received 200 milligram of vancomycin
Vancomycin.
vancomycin as an IV loading dose. The peak plasma concentration of vancomycin was 28.5 milligrams per liter. The apparent volume of distribution is
We remember how to calculate that? Dose divided by VD is equals to the dose divided by the concentration, and that will give us 70. So when we adjust for per kg, then we end up with 1 liter per kg. Otherwise, in its entirety, is 70 liters. Okay, 1.5. Someone read 1.5.
A 55-year-old woman is brought to the emergency department because of seizures. She has a history of renal disease and currently undergoes dialysis. She receives an intravenous infusion of anti-seizure drug X. Which of the following is likely to be observed with use of drug X in this patient?
Okay, we know seizures. That is abnormal electrical activity of the brain that will lead into muscle spasms and twitches. Now, this person has a history of renal disease, undergoing dialysis. Dialysis is just a medical process. In a way, it's like creating an artificial kidney, because the normal kidney is not working. So we redirect the blood to go to a dialysis machine, and the same process of diffusion happens such a way that the wastes will diffuse into the machine, and the clean blood exists from the other end and comes back to the human body. So this person has a renal disease. If the person has a renal disease, what happens to the half-life of a drug? Hello?
I think the half-life will increase.
Why? You're right. The half-life will increase, but why?
because the kidney will not be eliminating the drugs effectively.
So there's reduced elimination. In that context, if the half-life increases, what are you supposed to do with the dose? If more of the drug will still remain in the body, do we
You
increase the
reduce
dose already? Yeah?
you reduce the dose.
So what is the correct option?
D.
Let's see. Good. Because the patient has a renal disorder, she may not be able to excrete the drug effectively. Therefore, the half-life of drug X will be prolonged. As the half-life is prolonged, the dosage must be reduced, so the patient will not have serious toxic effects of drug X. Next, 1.6.
A 68-year-old woman is brought to an emergency department of treatment of myocardial infarction. She is currently taking clopidogrel and aspirin daily, as well as...
So take it afresh.
Okay, a 68-year-old woman is brought to the emergency department for the treatment of myocardial infarction. She is currently taking clopidogrel, which is an antiplatelet agent, and aspirin daily, as well as omeprazole, potent CYP inhibitor for heartburn. Which one of the following is the most likely contributor to the myocardial infarction today?
Do we understand what myocardial infarction is? Myocardial infarction will mean like the heart cells don't receive enough oxygen. So they don't receive enough perfusion, they don't receive enough blood, so they start to die. That's a myocardial infarction. And platelet agent, what is the purpose of platelets in our blood system?
Clotting.
Clotting, very well. So if the drug is antiplatelet, what does it do to clotting?
It inhibits clotting.
It inhibits clotting. Now, will inhibiting clotting contribute to myocardial infarction, or clotting is what will contribute to myocardial infarction? In blood vessels, if the blood vessels are just patterned and the blood is flowing freely, and in which case, that's scenario A. Scenario B is a situation where the blood vessels have some clots. In which case, can the heart miss the supply of blood?
In the blood vessel where there is a clot.
Okay. So when we deal with the clots, we minimize the chances of myocardial infarction.
Yeah.
Now, which of the following is the most likely contributor to her myocardial infarction? She is currently taking clopidogrel and aspirin daily, as well as omeprazole, potent CIP inhibitor. Sasa wale screenshotters walichukua notes zetu watuambie vile tuliongea juu ya clopidogrel. Clopidogrel is what is happening to omeprazole? When omeprazole is an inhibitor of CYP, and the CYP metabolizes clopidogrel. What will be the result? Okay, I take you to the notes so that you can make a response from there before we move. Can we read that last sentence, last bullet there?
Similar polymorphisms have been characterized for the CYP2C subfamily of isozymes. For instance, clopidogrel carries a warning that patients who are CYP2C19 poor metabolizers have a diminished antiplatelet effect when taking this drug, and an alternative medication should be considered. Clopidogrel is a prodrug, and CYP2C19 activity is required to convert it to the active metabolite.
Going forward, what does omeprazole do? It's an inhibitor of those enzymes, isn't it? So if omeprazole is an inhibitor, is the person going to benefit from clopidogrel when they're also taking omeprazole?
No.
Yes or no? Okay. It is something that you will have now to read and digest. You get the answer? Clopidogrel is a prodrug and requires activation for conversion to an active metabolite. Because omeprazole is an inhibitor of that, clopidogrel is not converted to that metabolite, and therefore the antiplatelet activity is reduced. So this person is not actually benefiting from clopidogrel despite having it, because of a concomitant use of clopidogrel and omeprazole. Okay, see, the answer is very clear in the slide. Hello?
Yes.
Okay, 1.7.
Which of the following reaction represents phase 2 of drug metabolism?
Good. What was phase 1? Phase 1 involved what? And what was phase 2 involving? Phase 1 involved making the drug polar. Phase 2 involves conjugation. And phase 1 was mainly redox and hydrolysis reactions. So in which case, what will be the phase 2 thing here? Amidation is adding an amine group, which we said that was phase 1. Hydrolysis is a breakage. Oxidation is when we reduce the electrons. Reduction is when we add the electrons. Sulfation is when we add a sulfite group, and therefore that will be the conjugation reaction. Okay. So can we, the last one for now, hata mshapata jibu, a pharmacokinetic study of a new antihypertensive drug is being conducted in healthy human volunteers. The half-life of the drug after administration by continuous IV infusion is 12 hours. Which of the following best approximates the time for the drug to reach steady state? I had told you, okay, the steady state part we have not talked about, but generally, how many half-lives would a drug take to almost reach, for the entire drug to almost be eliminated?
4 to 5.
Yeah? 4 to 5 half-lives, isn't it?
4 to 5.
Okay. So I want us to go next. I think I will now take the next slides to the steady state, but we have the answer. A drug will reach steady state in about 4 to 5 half-lives. So that one, we can be able to proceed from there. So let's go back now to our slides. So I want us to go through that part very quickly. Then I'm looking for the word steady state. Si hapo tulikuwa tumeangalia hiyo and the clinical situations, design and optimization of dosage regimen, that one. That is the slide I was looking for. Can we be there now? Somebody to read?
Types of therapy: single
Yes.
dose, e.g., zolpidem for sleep induction, continuous administration, IV infusion, fixed dose of fixed time interval, e.g., 1 tablet every 4 hours. Effect of repeated or continuous administration leads to accumulation of drug. Steady state concentration achieved when rate of drug administration equals to rate of drug elimination, results in relatively constant plasma and tissue levels.
Okay, so we have said we can have types of therapy. We can give drugs as single dose, or we can give continuous administration. Single dose is when you give a drug once and you hope that it achieves the effect. Continuous administration is where you can say we are graduating these doses, maybe give them after every this time. Or for example, fluids, you can give them over several hours. The word I was looking there is the steady state concentration. This is a state achieved when the rate of drug administration equals to the rate of drug elimination. Now, initially, when you give a drug, the drug will get to its half-life, whatever the amount of time the half-life is. If you give a drug in the morning, for example, whose half-life is 6 hours, by midday, we'll expect only 50% of the drug to remain. So 50% of the drug will be there, and 50% will have been gone. So what do we do? By the time you give us a third dose, how much percent of the drug will still be there? It will be 50% or 50%. That will be 25%. And that is why we can play around with the dosage forms and the way of administering the drug so that we reach an equilibrium where the amount administered and the amount eliminated are the same. In other words, we will not go below the drug levels that are required to give us the effects. What is the risk of the rate of elimination being faster than the rate of administration? What is the danger if the elimination rate is faster than the administration?
The drug action will not be effective because the concentration in the body is not effective to meet the demand.
Good. It will not be the effective dose. Okay. Yes, and that is a very serious implication, especially for the nursing profession. When we say a drug formulated for administration at particular hours of the day, these considerations are in place. You can imagine a drug that is supposed to be given every 6 hours, because that is the period we have estimated that we will maintain a steady state concentration. And then this drug is given now, and then it waits for 24 hours. You'll give 24 hours later when the effects have actually went off completely. Okay, so we got the implication of the steady state. Continuous infusion regimens.
Okay. Drug enters the body at a constant rate via IV infusion. Most drugs undergoes first-order elimination. A constant fraction is cleared per unit time. Elimination rate increases with plasma concentration. For plasma concentration over time, rises gradually after infusion starts. Steady state, that's the rate of elimination is equal to rate of administration. Plasma concentration become constant at a steady state.
Plasma concentration becomes constant at a steady state, and that's what we want to achieve. Next. Steady state in relation to infusion rate. Doubling the infusion rate leads to double the steady state. Okay, let's now not trouble ourselves at that. Time to reach steady state concentration. I mean, time to reach steady state drug concentration. Let's read that one.
Time to reach a steady state drug concentration. The key points: drug concentration rises from 0 at infusion start to the steady state levels. Rate of reaching steady state level is determined by the elimination rate constant, which is related to the drug's half-life. So the steady state milestone, after the first half-life, 50% of concentration. After the second half-life is 75%. After third half-life is 87.5%. After 3.3 half-lives is 90%. Then after 4 to 5 half-lives, steady state is essentially reached.
So in other words, we reach steady state after we have administered this drug like 4 to 5 times.
Important note: half-life is the sole determinant of time to reach steady state. Rate of infusion does not affect how quickly steady state is achieved, only concentration vary. When infusion is stopped, drug concentration declines to 0, following the same time course as its rise.